Hey everyone, welcome to Tender Falcon. Today we're going to cover diagnosis and OMT for the knee and ankle. This is going to be a quick review video. Additional resources will be listed in the description below if you're looking for something more in depth or that covers the other core concepts. So let's go ahead and just get started with the tibiofibular joint. We know that the fibular head can move anteriorly or posteriorly, right? So going off that, what's the reciprocal motion of the foot and ankle? Now we can divide the movements as a preference for foot pronation or supination. Pronation consists of foot eversion, dorsiflexion, and abduction. And when the foot is pronated, the fibular head is going to move anteriorly. While supination is just the exact opposite. It's foot inversion, it's plantar flexion, and it's adduction, and a posterior fibular head. Now there are different mnemonics for remembering these. I've seen all sorts of things. I've seen the acronym for pedal, for pronation. So here's our P, E, D, A, and then we just add on an L. I've also seen people use the mnemonic of you put plants in the soup, plants being our plantar flexion, and then soup being supination. Either way, we just need to remember this because the question writers are going to include some of these exam findings to test whether we can properly diagnose the fibular head. So what would we see in a practice question? One of the great things about the COMLEX writers is that they use these consistent buzzwords to help guide us to the diagnosis. The bad is that they usually start by providing all these superfluous info about the patient. How the patient hurt themselves. It feels like a full life story sometimes. Guys, just go ahead and scan those sentences and just really focus on the exam findings because that's where you'll find those buzzwords. So let's say we get a vignette, we quickly scan the patient's history, and then we get to those exam findings. So the question tells us that the fibular head has increased posterior glide, already cluing us into a possible posterior fibular head diagnosis, right? So on top of that, the fibular head also has resistance to anterior spring, and there's weak dorsiflexion of the foot. So the resistance to anterior spring makes sense, right? Mostly because they already told us that there's increased posterior movement of the fibular head. So where does the weak dorsiflexion fit in? So when the fibular head moves anteriorly, it's because the foot is in pronation. So it's going to find the freedom with dorsiflexion, right? But we already know our fibular head doesn't want to move anteriorly. It wants to move posteriorly. So where's our freedom? With plantar flexion, okay? So meaning that the patient's ability to dorsiflex is therefore weakened. All right, so let's continue with that diagnosis. And our diagnosis for that patient would be a posterior fibular head. Let's go ahead and continue with that diagnosis. So how could we potentially treat this patient with, say, a direct technique? We have muscle energy, we have HVLA. When we're using a direct technique, remember to place them into the restrictive barrier. With a posterior fibular head diagnosis, the foot wants to invert and it wants to plantar flex right. So our barrier is therefore going to be eversion and dorsiflexion. So with muscle energy, once we place them into the barrier, we're going to have that patient push their foot immediately kind of back to neutral position. With HVLA, once they're in the barrier, take that knee through the rapid kind of flexion and then pull that fibular head anteriorly. And now before we move on, let's quickly cover some of those counter strain tender points for the knee, as these are always quick give me points. Here we have lateral and medial meniscus, and then we also have the patellar tender points, find them right here. Then from the posterior view of the knee, remember where the ACL and PCL points would be, and these are very high yield, so we know that the ACL is going to be more lateral to the medial PCL. And then of course we have, just for reference sake, lateral and medial hamstring, and then gastrocnemius tender points. All right. So moving on to the tibio-talar joint. So in a similar manner to how we needed to know that the fibular head motion, or needed to know the fibular head motion with foot movement, we also need to know how the talus moves. Now the talus is going to, right here guys, now the talus will glide anteriorly with plantar flexion, and it will move posteriorly with dorsiflexion. It's pretty straightforward. These are buzzwords that we just need to know. Be careful about the diagnosis here, guys, because the test writers are going to ask you to diagnose based on the movement of the talus or the movement of the tibia. So what exactly do I mean by this? Say we get a question on the COMLEX. Our patient has foot pain. Exam findings reveal the patient prefers a foot plantar flexion and is resisting dorsiflexion movement. So we know the talus is going to move anteriorly with plantar flexion, right? And the patient already prefers this movement. It's their freedom. So what's our diagnosis? Our diagnosis is going to be anterior talus on tibia. Now, what if we have a patient that prefers dorsiflexion instead? They're resisting plantar flexion. So if they prefer dorsiflexion, that means the talus has moved posteriorly, right? But wait, let's say the test writers also add on that through palpation they feel that the tibia is anterior on the talus. What's our diagnosis then? Our diagnosis would be anterior tibia on talus, which is just another way of saying posterior talus. All right, guys, just don't let that confuse you. Just trying to focus on those exam findings and what they're trying to tell us. All right, another COMLEX favorite is the ankle sprain. The mechanism can either be lateral or medial. And so for the lateral, otherwise known as the inversion injury, it tends to be the most common. With a lateral injury, what ligament can be affected? Usually it's the anterior talofibular, otherwise known as ATF, because it always tears first. And then you can also have calcaneofibular or posterior talofibular ligament injuries, but those are much less common. They could also ask you, because the foot is in supination during the injury, remember we said that the fibular head moves posteriorly with that movement, we can also compress the fibular nerve. Right? And then medial or eversion ankle injury, it's less common because of our awesomely strong deltoid ligament. But when we do see this injury, remember that it can be associated with a medial malleolar fracture. All right. Now, the test writers can go a step further with this and ask you to diagnose the somatic dysfunction of the foot bones. Frankly, I think it's a bit much, but they expect us to know this, and it can grab you some extra points on test day. So let's go ahead and cover the cuboid and navicular bone movement, which tend to be more high yield. Remember, the cuboid is lateral in comparison to the navicular bone, which tends to be more medial. And I've seen the word dropped pop up a few times in some of the textbooks I use. If you guys see it, just know that it means it's just another word for somatic dysfunction. So what actually happens when our cuboid bone drops? Well, it becomes everted, meaning it internally rotates. You can kind of see with the arrows right here. It internally rotates towards the midline. Remember, cuboid is lateral. I'm just going to write that right there to remind us. And likewise with the navicular bone, when it drops, it goes into inversion, meaning it externally rotates away from that midline. So how could we see this on a test question? You know, we have a patient, they come in with foot pain, they're very tender on the bottom of their foot on that plantar aspect, but they're especially tender on a lateral tarsal bone. Now, we know the cuboid bone is lateral compared to the navicular, and the test writers probably expect that we know this. So they're also going to add on to our findings by saying that the lateral tarsal bone resists inversion movement. So what's our diagnosis? When our cuboid bone drops into eversion, that's its freedom, and it's going to resist inversion movement. So our diagnosis is an everted cuboid bone. All right, guys. We covered the high yield diagnosis OMT for the knee and ankle. If you have any questions or suggestions for future videos, please leave a comment down below. Until next time, this is Tender Falcon signing off.